How's it? What's the weather like in Mumbai?
Oh, it's beautiful, nice and hot. It stopped raining, so you can see the humidity coming up.
Of course.
Otherwise, it's all good.
How many people do you expect to join?
Uh, Very difficult to say. It's Saturday, so
I
at
know.
least 50, 100 should be there. But the only
Yeah.
thing is that the pediatric international stimulation conference has started,
Okay.
and it's on 17, 18, 19.
Right,
So
right.
it's clashing with us, but
Of course. And also you are in the middle of the Ganesh festival.
yes.
It must be a little subdued lately, right? Because of
Oh, it's
all the
totally
pandemic.
subdued.
Yeah.
In Bombay, you're not allowed to, more than 5 people can't meet in Bombay.
Right, right.
The government has done very well.
Are your numbers coming down though?
Yeah, numbers are, in fact, it's going vice versa. The numbers were down for last 2 months.
Okay.
Over last 2 weeks, the numbers have started coming up a little bit.
Okay. Yeah, it's impossible to maintain this level of social distancing for too long.
Yeah. So Neil is the master of ceremony. He is one of
Hi,
our
Neil.
Hello.
executive member in the Mumbai IAP.
Nice.
He's chief intensivist at Surya Hospital.
Nice to meet you, Neil.
Hi,
I
Nidhi.
see Dr. Jadhav is also online. Hi, Dr. Jadhav. How are you?
Oh, yeah. Hi. Hello. Hello, Dr. Alka Jadhav.
Oh, you're on mute. Dr. Jadhav, you're on mute.
Hello.
Now I hear you.
How are you?
I'm very well, thank you. Good to see you.
Yeah, I know. We completed the study. Now let's see how to go
Will
ahead
you
with
get
it.
the report? You will get your benchmarking report. I just got the benchmarking report template and some data. So maybe within the next 3-4 days, you will get it.
Okay. Wow, it must be. Let's see what is the interpretation.
Exactly. Yeah. It's a
But
challenging time to finish the study because of the pandemic, but we're very lucky everybody was able to.
okay, good. Nice to really see you and nice to chair your session.
Thank you so much. I am really grateful for the invitation. It's always fun to see all my friends in Mumbai. It's a shame we can't meet. I was there twice in the last 10 years, but now I don't know when travel will start again.
Maybe 2 years more.
Exactly.
At least a year more.
At least a year. Yeah. Yeah.
Yeah. But we would like to collaborate with more studies related to PICU and pediatric nutrition.
Sure, sure. Yes. I think once things settle down, we should think about next steps where you actually look at certain questions together. Yeah, your hospital, so many hospitals in Mumbai have so much potential for that kind of collaboration.
Yeah, we'll do that. Do you
I was, sorry?
Do you have any short-term course in pediatric nutrition? I have 3 nutritionists with me.
Okay.
So if
I think we don't run as courses as it's so difficult because the clinical work is crazy here and we are always running around clinical stuff. But there are many people who've come over to spend some time with us. But in the absence of travel, we usually refer people to Aspen and Espen because they have all these courses that they've worked very hard on in trying to develop. But the best thing is to have a group locally that meets and someone like you guiding them. It's the best way to create a culture where everyone's very aware and then constantly engaging in these topics. There's also a lot of quality improvement efforts related not just to nutrition but other aspects of PICU. It's really exciting time actually.
Yeah.
And with Zoom now, we've been forced to become good at communicating.
Yes.
Virtually.
True.
And Neil, where are you based?
I am at this children's hospital in Santa Cruz, Mumbai West.
Okay. Yeah.
Surya. I'm looking after the PICU over there now.
Nice. Yeah.
Taking baby steps in the field, trying to establish some teaching programs and all that stuff in PICU.
Sure. Yeah. No, that's what matters, because you get very busy clinically and it's easy to get lost in the clinical work. But if you step up and provide that kind of academic environment, a lot of young people get motivated and the field moves forward. Otherwise, we land up with very little evidence base, and it's frustrating then.
Trying to take a few steps in those fields now.
Sure, yeah. Are you seeing, whether it's Santa Cruz or at Sion and other places, a lot of children with COVID?
So I think we went through the past, 3 odd months in which we tested a whole lot, but nobody really ended up coming positive.
Okay.
But now we've started to get an occasional stray positive, but nobody really very demanding, at least in our setup over here.
Sure, that's good. Yeah.
I'm not sure how it is at Sion, ma'am.
Sion is actually now, initially we have seen almost 49 or 50 COVID in last 6 months, but now it is declining. It was more of PIMS rather than active infection. Active cases maybe 15 to 20 around.
Okay. Now you're talking about 15 to 20 adults and children, or just children?
No, children.
Just children. Okay.
Yeah.
Yeah, that's been the biggest blessing for us, that the kids have been spared so far. In the US, unfortunately, there are states where there are differences in vaccination rates. So I live in Massachusetts, and here the vaccination rate is very good. We have more than 85% of our adults vaccinated. So there are very few cases here. But if you go to Florida and Texas, it's not a very good scene right now. Their vaccination rates have not been good.
Mumbai being crowded city, yesterday there was a report that almost 80% of the population have developed the herd immunity,
Sure, yeah.
Yeah, so this means probably the pandemic is on decline.
Correct. I read that report. They tested antibodies and found 80% to have, that's good. I think it's going to be a combination of vaccine and herd immunity, which will get us, and then hopefully the COVID-19 will become like the old COVIDs in the last 20 years. We've had other kinds of COVIDs that are circulating in the world, but at a low level, not a pandemic level, because we've developed a good herd immunity for them.
Yeah. Probably, and better vaccines will come, which may give a protection. Right now, we are using our indigenous India prepared Covishield and Covaxin, and it's giving fairly good results. Fortunately,
very nice.
Yeah.
It's very nice that India has the talent and the resources, and you showed that you can develop the vaccine fast, and then the amount of vaccination that you've done in India is fascinating. It's very nice.
On 17th September, there was a record break vaccination because it was Narendra Modi's birthday, our PM's birthday.
Oh, yes, yeah. Very nice.
So that's slowly but surely India is changing, especially when we have seen the India 40 years ago and now. There's a lot of change, and over a period of next 10 years, there will be a significant change.
That is so nice to hear and watch. And I think the change is happening at the grassroots level. It is people within their communities, people doing a lot of charity in addition to advancing the field. It's very nice.
Yeah, and computer literacy has actually got so many things.
Right, yeah. Well, that's the biggest strength of our country, the computer literacy. We have to work on that.
Good evening, Dr. Sheikh. Good evening, ma'am.
Yes, how are you?
Very, very fine, ma'am.
After a long time, I saw you. You are just the same.
Oh, no, I'm not really sure about that, ma'am.
No, I'm quite sure.
I don't know, maybe a little bit of graying around the temples.
That's okay, but that same smile, infectious smile is there. So
Looking forward to learning from you again, ma'am.
my
We
God.
started off with learning with you about nutrition, and
Yeah.
I think after what 12, 15 years, it's coming around to learning from you again. I'm really
No,
looking
but
forward to the opportunity.
yeah, but we will definitely form a nutrition intensivist group as what is suggested by Dr. Mehta. And
We
we'll
should.
Yeah,
We should, ma'am. We should.
definitely.
Somehow we get so caught up with things like ventilation and inotropes that we neglect nutrition.
Becomes a though it is a backbone, becomes probably a side bone.
Yeah. Yes, ma'am.
There's still some time to start.
2 more minutes, 3 more minutes.
Yeah.
Is around, what time is it here? It's around 11 on a Saturday morning here, which is a very nice time to drive because there's not much traffic. It's really good. We here, of course, my ICU is busy. I'm at work right now, but not actually in the ICU working, and it's really busy. We've been seeing all the winter viruses, which we don't normally see at this time. So there's a lot of RSV and other viruses, and people who have not been exposed to those last winter because of the social distancing probably have lost some immunity. So we are seeing kids sicker with simple viruses that we didn't expect that.
So we actually went to something like a similar thing past 3 months. It looks like RSV has come and kids are coming back much sicker than they were last year. It seemed like COVID seemed to have swamped everything, and with the strict lockdown, everybody was inside. And this year, it seems like the RSVs, rhinoentro, etc., come back with a vengeance, and they're needing a lot more respiratory support, a lot more of them on oxygen, a lot of time to come off oxygen, things like that. And it's been even kids with relatively normal nutrition, normal immunity, and not only the NICU graduates who coming in a lot sicker this time.
Correct. Yeah, very true.
And it's staying for a longer. Even the basic rhinovirus and cold cough, they are staying at least for, they're being symptomatic at least for 5 to 7 days.
Yeah.
And it's not
Very
that
true.
they just have a fever and cough for 2-3 days and paracetamol and they're fine. Neil Mahesh has joined.
Good evening, sir.
Good evening, Mahesh.
From our side, we have Dr. Sanjeevani Masavkar. She was our in charge of intensivist. She can also will discuss with her experience in PICU, because
Sure.
I have not been going to PICU per se.
Sure. Yeah.
Leena. Hello.
Hello.
Hi, Leena.
Yes, ma'am.
Yeah.
Hi, Leena. Sanjeevani, you want to just switch on your camera? You'll come in front so we can see you. Bhavik, your screen is blank. Either you remove your screen or put something there, no?
It is 8:30.
Okay.
And we have our dietitian who's going to discuss it, Divya Ananta Subramaniam. She is very much interested in intensive nutrition. She was one of the co-member of our PICU nutrition project. Divya, we would like to see you also.
It's a Saturday evening. I can understand why video should in
Crowd
many
is
places.
little less.
You deserve your.
It's 9:30, 8:30 over here. So let's start with it.
Amish
hello.
bhai,
Good
Permanent
evening.
sir and Mahesh is there. Mahesh sir is there.
I know, nice one.
Yeah.
Mahesh, you want to switch on your video?
He switched on audio.
Okay. So good evening, everyone. Yeah, Mahesh is up. Yeah. Good evening, everyone. Thank you for joining us on a Saturday evening for the second part of Back to the Basics. Last time we did fluid and electrolytes. This time we are doing nutrition. We had a good talk by Shasha yesterday on parental nutrition. And I'm sure we're going to have a very good talk today on enteral nutrition by one of our colleagues and one of the world-renowned person in nutritional in pediatric intensive care. Before we start, I'd like just to say a few words for Nilesh. Nilesh has been very helpful. I remember I messaged him on 22nd of June that, we want to keep this talk. And within 12 hours, as soon as he saw it, he said next day, yes, I'm agree. And he was the first person to agree straight away that, that he'll be giving this talk. So really appreciate that. A lot of you might not be knowing, but Nilesh was our registrar and he's a batchmate from KEM. And it so happens that, during that time, most of us who were working with him, all of us have taken up ICU. Nilesh was a senior reg. Together with that, Rekha was there. Rekha is a consultant in Wadia. I was a senior SHO, and Pamanand was the house officer. So you can see that in that batch, 4 of us have become an intensivist. So, it was a very good fun that we had at that time. Not taking much time, I would progress and just ask Dr. Mahesh, our chairman of the next chairman for the intensive care chapter, to say a few words. Mahesh.
Thank you, Amish, for the invite. And sorry, I could not join yesterday because I was traveling at that time. I wish I could have joined for that TPN course as well. But it's a wonderful activity that we have started from Bombay branch, and kudos to the present office body. Without wasting time, I'll request the faculty to start his deliberation. I'm keen to listen to him because this is one topic which is so common and so obvious. I suppose most of the research work, when you talk about as far as outcome, this enteral nutrition gets always grade A evidence. Whatever topic, whatever I have gone through, may it be head injury, may it be shock, wherever. I think the outcome related to enteral nutrition is always grade 1 evidence. So I'm sure they are going to give us a wonderful information. So over to the faculty to start his deliberation. Thank you very much.
Thank you both. Thank you, Amish, for your kind words. I do remember very fondly our time. I actually see Rekha Solomon on. I don't see her, but a big hello to her. You taking me back to the 1990s in Mumbai, which was a magical time for all of us. 1980s, actually. What I'll do is I'll share my screen, and I just want one of you to just give me a shout out to say you can see my slides and hear me.
Yes, we can see your slides and we can hear you.
All right, and now you can see the slides in a slide view.
Yeah.
Yes, we can.
Yes, we can.
Perfect. Thank you. Thanks for that. Thanks again for inviting me. Mumbai is a very special place in my heart always. So when Amish mentioned the opportunity to see some of you, I thought I would do that. Again, just as a quick example of where I am. So I traveled a long way.
Nilesh, before I just made a brief intro. Before you start, sorry, Neil was.
Oh, it's no worries. Yeah, go ahead.
Neil, you want to just do the formal introduction of everyone?
Dr. Nilesh, allow me to delay you a little bit. I'd just like to give a brief introduction. So Dr. Nilesh has done his initial medical studies over here in Mumbai at Nair Hospital and then KEM and Wadia Hospital, and is currently a professor anesthesia at the Harvard Medical School, and is well known for a huge amount of work on enteral nutrition, which is going to be our topic of discussion today. We did parental nutrition yesterday. We are on to enteral nutrition today. Dr. Mehta is currently the chair, critical care, nutrition and metabolism, and the vice chair for quality and outcomes at the Department of Anesthesiology, Critical Care and Pain Medicine, and has been a past president of the American Society of Parental and Enteral Nutrition. Dr. Alka is also with us, and Dr. Alka will be moderating this session. Dr. Alka Jadhav ma'am has been a teacher to most of us and is currently a professor of pediatrics at the Lokmanya Tilak Medical College and Sion Hospital, and is in charge of pediatric gastroenterology, hepatology, and nutrition, with many publications related to nutrition, and has established protocolized management or WHO protocolized management in severe acute malnutrition, and how do we take care of these children, severe acute malnutrition treatment unit, and is credited with the first pediatric endoscopy unit in a public hospital in the city. Welcome to both of you. Dr. Nilesh, would you like to start? And
Thank you,
Alka
Neil.
ma'am, you can look at moderating a session, please.
Yes, sure. Thank you.
Thank you, Neil. Thank you again. So this is Boston. This is the Charles River. If you could look beyond the tall building on the right, that's where Children's Hospital is located. This is what we call the Longwood Avenue. Longwood Avenue in Boston is a very popular area. It's almost like a mecca for medicine, if you like. Some of the leading adult hospitals all around us. You can see the Harvard Public School, School of Public Health, the Brigham and Women's, Dana-Farber, the Beth Israel, Joslin Diabetes. And then right in the middle is Boston Children's Hospital. And that's the front door. And right there you can see our critical care dedicated transport ambulance waiting to be deployed. So this has been my home for almost 20 years now. And I'm delighted to spend the next 40 minutes, I think. And we can cut it short. So Amish, if time is the essence, please interrupt me and we can have more time in discussion. I will not disclose any commercial products. I have no conflicts related to this talk. What I thought I would do is Amish asked me to talk a little bit about the basics and pertaining to enteral nutrition. And because nutrition in critical care is not in a silo, you can't only talk about enteral and nothing else. So to introduce the concept, allow me to take you back to some basic concepts of how we think about nutrition in the critically ill child. We talk about outcomes related to nutrition. Dr. Mahesh mentioned there's a fair bit of studies now that seem to hint that we might not want to miss these signals between a simple therapy like nutrient delivery and important outcomes. And finally, we'll address the controversies related to enteral nutrition to end this. So let's start with the basic concepts. Now, amongst the basic concepts, on the top left of this slide is Sir Cuthbertson. He's a biochemist from Glasgow who in the earliest part of the 20th century, right after the First World War, began to conduct some experiments that have guided us in terms of understanding human metabolism. What he did was studied soldiers with long bone injuries, and he was interested in bone metabolism. So he started measuring calcium in their urine. And what he found that in addition to calcium, there was a ton of nitrogen and phosphorus, which was being leached into the urine. And he said, where is that coming from? And he was very curious that there is some other organ which is pouring out nitrogen, and there is this complex metabolic response to this injury. And that's where some of the initial foundations of what we understand, and I've tried to summarize it in a very simplistic cartoon here. So on the left, you see critical illness in the form of trauma, sepsis, burn, surgery, any type of critical illness. And then what happens as a result of that is perhaps a very well known aspect now, which is breakdown or lysis across all three substrates. So we have on top lipolysis releasing a lot of fatty acids with ketones that are now available during illness for substrate as a substrate to be used by organs. At the bottom, you see glycolysis with a lot of glucose. You all see it in your critically ill patients, hyperglycemia, but this is essential glucose that is available for brain, RBCs, kidneys. And right in the middle is the most important one, which is muscle breakdown. Now, the reason you have these adaptive responses is because back in the hunter-gatherer days, there was no food available. There were no pediatric ICUs. No one provided enteral nutrition or parenteral nutrition. So if you could not hunt because you were injured or infection or down with infection, you stopped. And as a human race, we would have gotten eliminated if we did not develop ability to find substrate within our own cells while we are healing. And that's the premise of this metabolic stress response. The first part about this metabolic stress response is that it is driven by this neurohormonal cascade and requires a lot of energy to drive it. And this was the myth or the controversy that we will talk about in the next couple of slides. So is this truly associated with a big energy burden? And do we need to feed people a lot of energy to account for that? To understand that, we go to the cell. And what's happening at the cellular level is when we consume carbohydrate, protein, or fat, these are all combinations of carbon, hydrogen, oxygen in various combinations. And the cell utilizes oxygen to oxidize these nutrients. And the oxidation of these nutrients is described here in this equation, where carbon dioxide is eliminated and water is produced, and then heat is produced. And it is this heat which drives the metabolic um, functions of the cell. If you could measure this heat production, that would be the concept of direct calorimetry, and that would allow you to understand how much energy is being produced, expended by the cell. Now, there are at the bottom left in adults who are healthy and are able to, there are direct calorimetry chambers, and you can run inside, and with the change in temperature, one can determine what your metabolism is. Clearly, in our environment in critical care, we can't do that. So what we do is what is known as indirect calorimetry, which means we utilize the other part of this equation where carbon dioxide is produced at a constant level and oxygen is consumed at a constant level and at that rate. And if you could measure minute to minute oxygen consumption and carbon dioxide production, you might be able to determine indirectly the metabolic state of this individual, or the energy produced and the energy consumed. And this is exactly what happens with indirect calorimetry. You can see the left and right bottom pictures showing indirect calorimeters on an unintubated and then one attached to a ventilator here. So what happens is, using these constructs of VO2, VCO2, which we can measure at the individual cells, but we can measure them at the respiratory level, so almost the bulk oxygen consumption and carbon dioxide production. And based on some fancy equations, which is very interesting reading from the early 1900s, we can derive resting energy expenditure. And this resting energy expenditure that is derived by indirect calorimetry is thought to be the gold standard, or the accurate measure of energy required by individuals during stress. Here's an example of an extreme of critical illness. So of all the illnesses humans have endured during evolution, burn injury is dramatic. It is very striking example where the metabolic stress response is almost, it's furious. It's like an engine revving up when someone endures a severe burn injury. What you're seeing on the x-axis is a timeline after burn injury: 1 week time to full healing, 6 months after healing, and up to 12 months after healing. And on the y-axis, you see the metabolic rate measured. And you can see if 100% is what would be normal or expected for a person, in this case, children with burn injury, right after injury in the initial phases, you see almost doubling of the metabolic rate. And it doesn't come down to normal up to even 1 year after. So this is a severe case, and it talks about the concept of hyper metabolism, elevated resting energy expenditure. And we see that in some critically ill children even now, but we don't see them in all. And I don't know what is the true reason. It's probably evolution, but it's more likely the modern pediatric intensive care with pain control, sedation, ventilation, which is much more kinder and synchronized, and therapies like surgery and antibiotics. As a result of something in combination, what we are seeing are these two pictures which depict the same, which is time on the x-axis and predicted the percentage of what would have been predicted. That means just like in burns, it was up to 200%. How is it in relation to where this child should have been? Where is the child for metabolic rate? On the left here is children who have undergone stem cell transplantation, and on the right, children with severe traumatic brain injury. And in both these groups, what we've shown in one, and that's on the left, and then a group from Pittsburgh that is shown on the right in TBI, you see the opposite, or not the degree of hypermetabolism that we thought in the early parts of the 20th century. And in fact, what you see is low energy expenditure. So giving rise to this new concept, which is perhaps that in some patients or in large number of patients, there is hypometabolism. And this construct was very interesting. It started evolving over the last 20 years. And if that is the case, if you are using the prediction or the non-measured energy expenditure, the predicted with equations, where this red line 100% or the 100% here is where you would start feeding these kids, then it's no surprise that in an ICU like ours many years ago, these 30 patients were fed according to predictions, but when we measured them, the actual requirement was low. So we'll end up overfeeding these patients. These bars represent cumulative overfeeding in calories on the y-axis over 1 week. So in 1 week, in some patients, we gave additional thousands of calories, which they did not require. And that concept of overfeeding is now firmly embedded, and we need to be mindful when we talk about prudent or optimal strategies. The last thing I'll say about the basics of metabolic stress is this, the most important feature, which is amongst all the pathways, it's the muscle breakdown, which is the most important and also consequential. The muscle breakdown releases a lot of amino acids, and these amino acids are utilized by the body when the body is healing from the injury, but does not have external substrate. And these amino acids get reprioritized. They are used for protein synthesis and tissue repair, or to fight inflammation by making acute inflammatory proteins, or they go through the gluconeogenetic mechanism to get glucose. And this, as you can imagine, back to the hunter-gatherer days, extremely important, because muscle is the largest organ in our body. And if you could sacrifice some muscle, but then survive and get better and heal and go back and hunt and gather, you survive as a race. However, if this continues for a long period of time, you can imagine now the side effect of a prolonged muscle breakdown and a resultant ill effects that you don't desire. And this is what we in the modern ICU are dealing with. Back to burn injury. So think about the burn injury. On the left are some elegant experiments from Galveston, Texas, which is a very leading burn injury center for research. And what you can see here is using stable isotope technology. They have demonstrated in the shaded bars or the black bars, the degree of proteolysis or protein breakdown on the left and protein synthesis on the right, both of which are elevated compared to the empty or the white boxes, which are in normal or controlled children. What you can see is both are elevated, but clearly the proteolysis is much greater than protein synthesis, resulting in this protein balance, which is negative. A profound protein balance, which continues for a long time, will result in stripping away of important muscle protein. So this we and others have shown in a variety of other clinical conditions, where once again, you see on the left, the top section describes healthy children, where the yellow bar is the protein synthesis, the black bar is the protein breakdown, and the yellow bar is the protein balance. The black and the gray bars are the breakdown and synthesis. So when we are in health, synthesis is greater than breakdown, resulting in a positive protein balance. But if you look at patients with sepsis, thoracic surgery, critically ill, the black bars or the protein breakdown is always greater than the synthesis. Both of them are elevated, but they are still in a negative protein balance. So this is an important concept to understand. And based on these concepts, let's look at how does this cellular metabolism and the reliance on substrate and the possibility of underfeeding and overfeeding impact outcomes. When we talk about nutrition and outcomes, clearly we have benefited from modern pediatric critical care advances where mortality is no longer the main outcome that you're concerned with. Here is one example of what's happening in modern ICUs. This is from a center in South Africa, Cape Town, but this is a similar story everywhere, where if you start from 2000 to 2018, even in the short span of time, both elective and emergent admissions, there is a steady drop in ICU mortality. And many of our centers here will have less than 2% mortality. And therefore, mortality cannot be the study or the trial, because you would need thousands and thousands of patients to show an impact. This decrease in mortality has been very helpful, but because mortality is no longer the only thing we are focused on, we have switched our emphasis to other outcomes. And this is a topic for an interesting talk in the future, and that is the long-term outcomes. What is happening to the child after they get discharged from the pediatric ICU? Yes, they survived. What's their quality of life? Are they back to their functional outcomes? And this has become one of the key aspects of critical care research in this century. And one of the big things about long-term outcomes, one of the areas which has become a focus, partly related to some of the basic concepts that we looked at in terms of protein metabolism, is the concept of frailty or muscle loss resulting in weakness and frailty. And this affects adults and pediatric patients equally. If you If you look at patients in the adult ICU, this is a JAMA publication just under 10 years ago, where in patients admitted with multi-organ system failure, there were muscle biopsies done in adults on day one, which is on the left, showing a pristine architecture of myofibrils and looking very healthy. But within 7 days, with acute inflammation and multi-organ failure, you begin to see necrosis, cellular infiltrate, and a classic scenario which results in the profound muscle wasting that we see in pediatric ICU patients as well. And some of these changes happen within a very short frame of time. And I'll show you some topics that are related to this, some data. Now, if you think of frailty or if you think of muscle breakdown in the ICU, the picture is multidimensional. On the left, there are catabolic factors, which include the classic inflammation and neuroendocrine adaptation that is so characteristic of this critical illness and the metabolic stress. But then there are these modifiable catabolic factors, such as immobilization. And this is a big area right now. Nutrition alone may not have the same impact as if you try to also provide mobility, early mobilization of your patients. So immobilization is a big problem. On the other hand, anabolic factors that we deprive patients for, physical therapy, very similar in theme of as in immobilization, but adequate protein availability. So if you do not have the ability to avoid immobilization and avoid inadequacy of protein ability, this muscle wasting is a given and there is no control over it, and it will start affecting outcomes. How do we measure this muscle wasting? So here are some new tools that have arrived in the ICU. We on my ICU routinely do muscle ultrasound, and ultrasound muscle, this is a paper from United States, a single center, 34 children who were mechanically ventilated. What you can see on the left here are the percent change in muscle thickness over the first week, and some of them within 3 to 4 days. So you begin to see the diaphragm, biceps, tibialis, and the quadriceps. Quadriceps being the largest muscle, all showing a significant drop in their thickness. And if you look on the right, the percentage of patients, which is almost 50% with greater than 10% thickness loss. So there is ability with modern tools to actually visualize muscle loss in these patients. And muscle loss is an interesting concept, and there are various ways in which critical care folks can look at body composition. Not all of these are within our purview. We do a lot of studies related to BIA, plethysmography, ultrasound, as I've shown you, DEXA. We have availability of this close to us in the ICU because we are a research center with nutrition and metabolism interest, but it's not available everywhere. And anthropometry, which is available to us, which is extremely important in some kids, like the one in the middle with body wall edema and fluid shifts, becomes inaccurate. So it's a little bit of a conundrum as to how we are going to go and document and measure these as a biomarker of whether you are adequately providing nutrition or not. And without going into details of our work, muscle ultrasound of the quadriceps muscle is an interesting area, and I urge you to read about it when you get a chance. But on the left, you see a muscle ultrasound probe on the thigh of a child with the rectus femoris and the 3 vasti, which is together the quadriceps muscle. And we measure the thickness and the circumferential area. And we have documented, like others, very interesting findings in terms of these thicknesses in muscle ultrasound. And in our study, we also showed that not only is this an important tool, it's reliable. So you see the 2 graphs here. The left graph shows the correlation between the thickness and circumference measured by a CCM operator. So it could be my registrar or one of my faculty. And then on the x-axis here is a radiology expert, and it's bang on top of each other. You see how perfectly correlated. And when you take 2 individual operators, even their measurements are correlated. This is relatively new. As the ultrasounds have become better, the new protocols have become more refined. And as a result, we are now able to measure and use these in trials and studies. In fact, if you see here, the correlation, and this is an observational study, not a trial, therefore this is just a hypothesis generating, but the observations are relevant. On the left, you see the pink dots represent, just like I showed you that previous study, 0 is no change, and you get negative, which is up to 30% thickness loss. And you see in all our patients, multiple patients, only a few maintain their muscle mass, the rest lose muscle mass. And this muscle mass loss is correlated on the left with percent goal calories. That means if you are giving less than what you have prescribed, you are more likely to lose thickness. And this is true for calories and protein on the right here. So interesting examination. We are currently in the middle of designing and just about to start our trial of protein and early mobility, where we will use muscle ultrasound as one of the tools or biomarkers. And lastly, before we get to the nutrient delivery, the reason it's important to understand this muscle mass loss is because this muscle mass loss, as you see here in the top curve, acute loss and then comes back to normal over time, is associated with this is the muscle protein catabolism that we showed in the cartoon. These dashed lines here is the one associated with muscle mass loss, which takes a long time to come back, and then the function loss, which takes even longer to return to normal. And it is this function loss that we cannot afford in our survivors of critical illness. You can see in burn patients, on the right top is an isokinetic dynamometer. These burn injury patients undergo strength testing after they recover. And you can see on the graph here, the x-axis shows lean body mass. The y-axis shows one of the ways in which you measure the strength, and that's a peak torque. And there's a direct correlation between mass and function. So it's important for us to preserve muscle mass. So that brings us to how do we get about delivering nutrition, and thank you for bearing with me while I make this case. Now, the delivery of nutrition is obviously not straightforward. You need to have three aspects in mind. The optimal dose, how much? The safest route, how do I give it? EN, PN, is one superior versus the other? Should I just stick to one and not the other? Or is there a combination approach that together helps me? And then what is the time? Early, late, what is too early, what is too late? And at the same time, these things have to be individualized for patients, depending on, did the patient arrive with severe malnutrition and already with a very low muscle mass? Did this patient have a disease that is almost like burn injury, or is this disease where there is hypometabolism? And then how long is this disease going to continue? If I'm recovering within 2 days, you can probably ignore a little bit of nutrient deficiency and send me off and I'll be fine. If I'm in your ICU for 21 days and you fed me nothing, now that's a problem, probably. And therefore, the nutrient delivery is never in a silo. You need to think of all three concepts together. What do we do with nutrient delivery? These are observational studies that we've done all over the world. The first one that we did almost 10 years ago now, it was looking at energy delivery in the ICU. And what you can see in the blue line on days 1 to 12, it shows the percentage of the calories that were prescribed that actually landed up being delivered. And you can see in the first week, you barely hit 50% of what you prescribed. And in patients who received supplemental PN, it manages to go above up to 70%. So this is just the average adequacy, and there are clearly large outliers where some people barely get anything and some get a little more. Now, how do we determine what is the correlation? Because these are 500 patients and we can do multiple regressions and logistic regressions, and we can think about energy deficit in correlation to larger outcomes, in this case, mortality, because it was a large study. What we found is after accounting for severity of illness, after accounting for the site and several other confounders, there is a direct correlation between the percentage adequacy. That means how much of what fraction of what you prescribed did you actually deliver by enteral route only. We don't see any benefit of the parenteral route for energy, but for the enteral route, we see that when you divide patients into less than one third to 2/3, and greater than 2/3, it seems like you need to get to at least 2/3 to get decrease in mortality, or to be associated with decrease in mortality. So once you get to 2/3, there's not much more benefit to get above 100%, but we would recommend at least 2/3 based on these observational studies. And these have been replicated by several groups all over the world, including Singapore and Europe. Now, same story with protein. Protein, this is the second international study that we did. And this one was a larger study with 1,200 mechanically ventilated patients. And you can see once again, protein delivery on day 1 to day 7, barely reaching 30%, 40% of what was prescribed. And as a result, the same concept of a large protein deficit that you are accruing, if you truly believe that what you prescribed is the optimal amount the patient should receive. And as a result, what we look for is there an association between deficit and outcome in relation to protein? And once again, what you find is when you look at logistic regression and you account for all the confounders, including severity of illness, there seems to be a signal that as you increase the adequacy of protein, that means you deliver at least 30%, 40, 60%. Once again, the magic number is somewhere between 60 and 80. You don't get a lot more benefit once you go above 100, and you begin to taper off after 80% in most studies. But there seems to be a direct correlation with protein and mortality. Once again, only with enteral, not with parenteral alone. And this was PINS2, and it has been replicated in 5 randomized controlled trials, that there is a correlation or a correlation association, and also in a trial benefit of giving better protein delivery than not. If you think of some of our patients in the ICU, this is becomes relevant, because here we show in a single center our study of patients on ECMO at Boston Children's. And this is similar to severely surgically ill patients who've undergone major surgeries, and you can't feed them enterally right away. So you find that these are VA ECMO patients with multiple vasoactive agents, and in the first 1, 2, 3 days, barely any EN. These blue markers indicate trophic EN, which means we do start them on trophic, but can't increase. And it's only after day 7 that we begin to increase, and by day 14, we get up to 1 gram per kg delivery. So this is a problem if you were relying only on EN. The good news is that small amount of EN, up to 20% trophic, and in some cases up to 1 gram, we could deliver it, and there was no impact on both initiating and continuing on the UAC, that is umbilical artery catheter present, vasoactive medication, and we had no cases of necrotizing enterocolitis for decades now related to EN. But in order to get to at least 1.5 to 2.5 grams per kg of protein, we rely on supplementing with parenteral nutrition a small portion of our patients. And that's when you get up to 2.5 in some cases. And this becomes the case for supplemental PN. So while EN was able to be delivered, when EN cannot be delivered, do you give PN? I won't go into details of when is parenteral nutrition appropriate, because you spoke about this yesterday, but I do have a different viewpoint, because we are heavily invested in parenteral nutrition delivery, and we've done plenty of work ourselves. And the Aspen group continues to update its when is parenteral nutrition appropriate. How do I give appropriate parenteral nutrition? And I would urge you to read some of these recent publications that summarize the data. One study that made headlines was the PIPANIC study. You heard Sasha, a close friend of mine, describing that study. I have a slightly different take on some aspects of the study. And if you do a detailed dive, the study has a lot of problems with external validity. One of the big problems with the study is that it compares 2 extremes of therapy practice. One is PN is started within 24 hours if EN did not reach 80% of goal calories. You saw from thousands of patients of data, nobody gets to 80% within 24 hours. We know our PICU patients. That means universally, patients were randomized to start PN within 24 hours. This is aggressive approach. That means your central line is in, you ordered your PN right as the patient's admitted, and before the day is over, you have started parenteral nutrition. On the other hand, you delayed up to day 8. This is a center that does very good enteral nutrition. There were 3 centers, all of them do good enteral nutrition. So what I wanted to show you is the results were there's lower infection and shorter PICU stay in patients who had late PN, which means the early PN did poorly. If you look at the actual delivery of nutrients, this is from their paper. On the left column here is the enteral nutrition delivery in the PIPANIC study. If you look at the amount of enteral nutrition that both groups received by day 7, this is almost 50 kilocalories per kg per day. And in many of our studies, and many people have shown that 50 to 60 kcals per kg per day is way more than 2/3 of their requirement. So you start out by already giving a good amount of enteral nutrition. On top of that, then, if you look at the second column is the amount of parenteral. So clearly the early group, which is the blue bars, get an additional doubling of this with parenteral nutrition, and resulting in these differences between the total delivery of energy, which is shown in the third column. So here's the problem. The total delivery, is it overfeeding in the early PN group versus appropriate feeding in the late PN group, who already had enteral nutrition, started early and advanced appropriately? And this is a testament to those three sites because they did a great job with enteral nutrition. But my contention is the PN delivery was in the extremes, and the early PN, none of us do that kind of delivery. And it certainly was a case for overfeeding, which we've shown is problematic. Furthermore, when you design a study where you wait until 8 days to start PN, you're left with less than 25% of your patients in the ICU by the time you reach day 7, because I would pick you the common length of stay is not more than 3, 4, 5 days. And therefore, a study that looks at extremes begins to not have the kind of patients that you and I are interested in answering this question. And as a result, we have questioned some of the results of the PEPANIC and their interpretation. This is a subgroup that they did on newborns in the PEPANIC group, 200 newborns out of the 1,400 patients. And again, they found the same thing, decreased infection and decreased LOS, the length of stay in the ICU, even in the newborns, which we argued that these are probably patients where you need to be careful because they don't have enough reserves. What the authors found that, yes, they had improved outcomes, and note the percentage of patients that get infection. This is higher than any other center that we have seen. So there's some problem with the kind of patients. But yes, while based on this, even in newborns, we would not start PN on day 1, which means the early enteral nutrition arm, and I agree with that. But the patients who waited until day 8, they reported 3.5 and 5.4 hazard ratio of hypoglycemia. This is severe hypoglycemia, and this high risk of hypoglycemia in a newborn is unacceptable to wait. So it sounds like the possible pragmatic timing may be somewhere in between. And this is an adult study that came out right in the middle of the adult and pediatric PEPANIC trials, which looks at it in a nuanced fashion, which is a pragmatic PN supplementation. They do indirect calorimetry to guide their energy expenditure, which means they try to avoid overfeeding. They only provide energy if they are not able to reach 60% by day 4, day 3, day 4. And if at that day 4, you are not able to reach 60%, then the supplemental group gets PN and the non-supplemental continues to advance EN. And what they found in this pragmatic and a much more practical study, that in fact, if you did PN supplementation by day 3, day 4, your infection rate was lower. So it's interesting. The data are beginning to form around the nuance, and we need to be careful. Again, you've heard the PN talk, but PN all over the world in our most recent international study is used in a very different way than the way that was studied in PEPANIC. Time to PN initiation, median is 3 days in over 3,000 patients in the PIN studies. 77% of the subjects who get PN are slated to stay longer than a week, and they are fasting and they have no way of getting EN to them. And therefore, this is a much more prudent way of starting PN at a delayed time, but not too delayed, and only in subjects where there is no chance of getting EN. And this is very different from a randomized trial, which divides patients into 2 groups. This is just a single center. In our center, we use, of all admissions, less than 9%, less than 8% of patients in a 3-month period. So we had 1,300 admissions roughly. Only less than 8% we use PN. And these are the indications on the right. So a small percent of total, and within that percent, even a smaller percent where we give supplement to insufficient EN. And we start PN only when EN is 0. And we stop it once we get to 50%. So we are using PN in a slightly different way. I won't show you my energy delivery data from PN in the interest of time. So EN would be the goal. However, EN has challenges. We can't always deliver EN. Several years ago, we looked at EN delivery and its challenges in a single center. And EN is repeatedly interrupted. in many patients, and in majority of those, these interruptions are avoidable. In 88 episodes of EN interruption, there's almost 1,500 hours of fasting, which we think is a problem because you are not maximizing the utility or the ability to deliver EN. And that's what started us on a 2-decade-long EN optimizing journey. We looked at what is it that causes EN interruptions. This is one of the prior papers. There are multiple such papers after ours which talk about similar things, which is feeding intolerance. The way we talk about feeding intolerance is a major problem. Procedures, we start fasting patients for procedures. Sometimes patient is going to have a procedure tomorrow and we don't know the time. Let's just start fasting now. And then after 24 hours, the OR is not ready or the radiology suite is not ready. And we continue to fast these patients. And these are completely avoidable long fasting for procedures. The problem is patients who have interruptions or have, if you look to the right, have significantly worsened outcomes. Their PQ length of stay is higher. Their PN use is higher, of course, because now you are depriving them of EN and therefore you're utilizing PN. The caloric goal is not reached, and the time to reach the goal is longer. And what's important is in all these patients, there is no difference in their severity. So it's just a matter of how we choose to feed them that the outcomes begin to be different. And the PN use is 4 times higher if your EN is interrupted or started late. What I would recommend is to look at the SCCM Aspen evidence-based guidelines, which goes into a lot more detail of various aspects of enteral nutrient delivery. What we are showing, what I wanted to hint at is, okay, does EN benefit critically ill children? Multiple studies that show associations between EN, and these are, you will never get a randomized control trial of EN versus PN or EN and no PN. So we will not have an RCT that needs to demonstrate benefits of EN, but many observational studies consistently show decreased mortality in patients who are early EN, optimized EN, and irrespective of their severity of illness. Is gastric or small bowel best? There are 3 RCTs that looked at gastric versus post-pyloric feeding, continuous versus intermittent feeding. As of today, there are no trials that have shown one versus the other to be superior. I think what practice has evolved over time is to start with gastric, and then if the gastric does not is not tolerated or not feasible, then people resort to post-pyloric feeding. And post-pyloric feeding is associated in some studies with early achievement of nutrient delivery goals. In our center, this is our post-pyloric paper that one of our trainees published just last year, and we looked at 100 patients, consecutive 100 patients prospectively, and we said, those that get post-pyloric tube, why do they get it, and how is the EN delivery? And if on the left, you see the reasons why we put post-pyloric tube. A quarter of them, we have tried gastric, and they have failed. Almost half of them, there has been a strong risk of aspiration. They cannot protect their airway. They've been shown to have aspiration before or recently. Another group is the non-invasive ventilation. We do have a large number of patients who either stay on non-invasive or are on non-invasive and threatening to get intubated, or were intubated and beginning to get to non-invasive. So these are the patients who potentially could benefit from post-pyloric EN. Give me 1 second. I see a chat. Amish, will you tell me if we are getting close to time?
Just continue. Still have time.
Thank you. The other concept is the time to initiate EN. Can we initiate EN early in severely critically ill patients? These could be patients like I showed you on ECMO, or patients on vasoactive infusions. And a lot of people, including part of some RCTs, have shown, if you look at the right column, after admission, most people over the years have started EN early, and even as early as 12 hours, and at least within 24 to 48 hours of admission to the ICU. We'll talk a little bit about that, but it seems like at least starting trophic feeds is feasible, and and it may not be associated with a lot of complications. Now, the desire to start early is because if you don't start early, it's very difficult to catch up the EN delivery. So this is a paper from a group of 5 hospitals in New England, which is my region. And what they showed is on the x-axis time and the y-axis the amount of caloric on top and protein on bottom delivery by enteral route. The gray bars are patients where early EN was delivered within 24 to 48 hours. And the white bars are after 48 hours. And when you delay enteral nutrition even by a couple of days, you begin to take a longer time to get up to the delivery of where you want to be. So 40 to 60 kcals per kg per day, the early group is very rapidly able to achieve. The 1.5 grams per kg, the early group is very rapidly able to achieve, whereas the late EN continues to have a lot of deficits. And these are patients who are matched for their severity of illness and type of diagnoses. So it sounds like early initiation and has benefits. Let's say we start early. How do we continue to progress and make sure that EN is optimized after starting it? And one of the biggest challenges there is all of us have different views. So each time, depending on who's the attending consultant on, or who's the trainee on, who's the registrar on, which nurse believes the patient is ready, that people keep changing the advancement. And that's where the concept of a stepwise algorithmic approach came out. And Tony Petrillo Alboreno, one of my colleagues, one of the first papers that came out in 2006, began to start examining before and after introducing an EN protocol, an enteral nutrition advancement protocol that talks, and all these studies, Hamilton is ours in 2014, all these studies show in the outcomes that the time to goal feeding, basically achieving where you want to, is significantly reduced when you use this approach, which is protocolized. That means every 4 hours, someone is going to increase the feed unless you have a expressed and a demonstrated rationale for stopping. And then if you stop every 4 hours, someone comes and assesses back. And these are mostly nursing driven protocols. So you're not waiting for a consultant to come in and say, oh yes, let's go further. And this allows you to have a much more reliable approach. This is our protocol from 2006. You can't read this, and these papers are published, so you can look it up, but the protocols are very similar. They think about who's eligible. They think about when can you start soon. They think about individualizing the concept, which means if the patient is malnourished, and if I'm anticipating greater than 5 days of fasting or NPO, I would consider putting a tube and starting enteral nutrition. And if I cannot do this, then I would think about initiating PN. So if you look at it, not malnourished or anticipate NPO for longer, but the patient is completely healthy, we may wait up to 7 days in those patients. And this is 2006, 10 years before the Pepanic study was driven. Most people practice this kind of pragmatic approach. But if you had a newborn less than 30 days who also was malnourished, and I anticipate that the patient will not get any enteral, we don't wait longer than 3 days. Same with malnourished patients, we don't wait longer than 5 days. And again, this is from 2006, and we've been following this since then for PN. And we've shown before and after introducing algorithms like the one that I showed you in the table, the gray, the dotted line showing the pre-intervention cohort, which on days of admission 1 to 12, on the y-axis is the proportion of patients that reach their goal. And you see how only 30, 40, 60% by the end of 10 days reach their goal. But if you have this stepwise protocol, a large number very quickly are able to reach the nutrient delivery goal. And this is all enteral nutrition. So enteral nutrition is certainly driven by these algorithms all over the world now. The algorithms focus on early starting, trophic as far as you can tolerate, and the moment you feel like the time is right and based on assessment, start a stepwise advancement and a very prudent definition and management of intolerance. And this is a big deal because there are many concepts of intolerance that are being challenged. One of the biggest concept is if you have gastric residual volume which is elevated, on its own, it's a sign of intolerance, stop feeding. And this we've challenged in multiple studies. We've done gastric emptying studies and shown that it has nothing to do with gastric residual volume. Of course, we don't ignore a large gastric vesicle volume if it is associated with other signs of intolerance, like vomiting, distension, and others, or if you have a high-risk patient. But just based on gastric residual volume, we don't call it intolerance alone. And this is one of the ways in which you address it. The last thing I'll say in the timing is, in our most recent study published just this month, we showed that the timing of EN plus PN, so both EN and EN plus PN, not PN alone, what we find is, yes, you don't really have to get to the goal by 3 days. That's the gray bar, and mortality in patients who get to the goal by 3 days. And the blue bar is patients who take up to 7 days to reach the goal. These two are almost similar. There's no rush to get to your goal in 3 days. You can wait up to 7 days. But if you wait longer than 7 days, either in patients who got only EN or EN plus PN, there is a significant jump in mortality. This is after accounting for severity of illness. These were propensity matched analyses. This is an interesting paper. I would urge you to look at it. It was published in AJCN. What's important is the goal is 60% of what you prescribe, not 100, not 80. So it's a pragmatic goal delivered within a pragmatic time, which is before 7 days. But if you would wait further, this is significant increase in mortality. So very fascinating, describing the nuance as opposed to the one size fits all crazy randomized controlled trial, two extremes. And now based on those two extremes, you suddenly say nobody should be fed for the first 7 days, which is a little far-fetched if you ask me. I will end with how we feed our patients, and we can talk about more things during the discussion, but this is just the final concept. So what do I do in my ICU? On the x-axis is the time from admission, day 1 to day 14, let's say. On the y-axis, it could be protein, but let's pick energy. We think about what percent of the energy delivery of the dose that you prescribe, and that's the dose up here, the blue line, that you prescribed is being delivered. The energy goal we determine as carefully as possible. So remember the concept of overfeeding. So you want to individualize the goal, and not everybody gets 100%, not everybody gets prescribed what a normal child with a predictive equation should have gotten. In some cases, we do indirect calorimetry. I have ability to do indirect calorimetry in some patients, and that's how we individualize the goal. This concept here, the gray triangle that I showed in the beginning, if you go back to the first slide that I showed you, the cartoon of the metabolic stress response, you saw that all breakdown of all the substrate and ability to get some energy from within your endogenous substrate. That's this happening in the first couple of days. So there is a little bit of energy that the body is getting from its own breakdown. And then we say, okay, we will aim for 2/3 of this goal within the first week. Let's try to be pragmatic based on all these studies that I showed you, not 80% like Pepanic, not 100%. So then we start. We want to avoid overfeeding. And then we start with enteral nutrition. Remember, we said early start. We start enteral nutrition within 24 hours and at the most within 48 hours after admission, especially if hemodynamic stability has been reached. So if you are standing there delivering fluids and raising vasoactives and worried about blood pressure, that's not the time to feed this child in the stomach. But as soon as the hemodynamics are stable, even if they are on some vasoactives, but they are on stable quantities, that's when we start. We then use our stepwise advancement, and this green dashed line begins to show enteral nutrient delivery, trophic to begin with, and then with the stepwise advancement, we continue and we monitor for intolerance as we do that. And it's a stepwise advancement. Every so many hours, the delivery goes up and we watch it. And our goal is to get somewhere here by day seven, which is 60%. So I don't need to worry. This patient is doing fine. I've not gotten to 100%, but I don't want to go crazy. Therefore, during that period, there is no role for early PN. However, this other patient, I am not able to advance. I'm staying on trophic or even zero, and the patient is either not able to advance. I've tried with the stepwise algorithm. I'm now day 7. This is now where I do not want to deprive this patient for days and days of poor feeding. In this case, by day 3 to day 5, somewhere here, I would start thinking about a pragmatic role for PN in some patients. PN, if we avoid overfeeding and if we provide aseptic precautions has been shown to be extremely safe in all modern ICUs all over the world. The numbers are so low in terms of complications with the modern methods that we use. So that's the concept of this red line, which is supplemental PN to boost it to 60%. But then I'm not indefinitely continuing, because at some stage I can start going up on the EN, and I will stop the EN once I get to even 50% of the goal, because I know by the next day or the day after, I'll get to 60 and then to 80% of my goal. So we use a very pragmatic, prudent PN delivery in select patients based on their individualized need, and then and stop it when necessary. So I think I will stop here in the interest of time. There are a lot of other things we could talk about, but what we've done is revise some of the basic concepts of metabolism, think about why nutrition and outcomes are important, but most importantly, think about nutrition as a nuanced practice as opposed to one size fits all. Not everybody is the same in the ICU. Not everybody should be fed one versus the other, low dose or high dose, early versus late, but an individualized approach. And I have other studies on individualized nutrition, which we can talk about if time permits, but I do want us to have a dialogue. So I'm going to stop here and end with some of these concepts that we discussed. And this is just a slide of my research group. Over the years, we meet in my backyard. Unfortunately, we haven't met in the last 1.5 years because of COVID precautions. But I would love to hear from you. My email, Twitter handle, everything is here. I would love it if some of you don't get a chance to discuss today. Feel free to reach out. I want to thank you all for the opportunity. And I think I'm going to stop sharing my slides for now so that we can allow Dr. Jadhav to take it from here and go to the discussion part of the session. There you go. Dr. Jadhav, you're on mute.
Dr. Alka ma'am, we can't hear you.
Now am I audible?
Yes, you are.
Yeah. Okay. So thank you, Dr. Nilesh, for really such a wonderful, it was very, very informative and probably an eye-opener for many of us we are really not doing such an intensive nutrition monitoring in PICUs by and large at last. What has impressed or what practices we can follow are probably doing the muscle ultrasound on day one, serial muscle ultrasound, because most of us, we do have ultrasound machine as a bedside diagnostic tool. So that will really help us. So maybe a 10% reduction will be definitely an eye opener for us. Second is what we thought. I mean, I have one or two questions before we go to the questions on chat box. Is is the gastric intolerance associated with GI or the post pyloric intolerance also?
That's a good question. As I mentioned, there are some RCTs that have compared it and some observational studies. Because there is not a very large number of patients who have done a head-to-head all gastric, all post-pyloric, the data are difficult to interpret whether one or the other is absolutely better than the other. Most patients get started on post-pyloric after they have failed gastric, and majority of them actually tolerate post-pyloric and are able to reach much faster their goal. Now, the problem is that in some centers, there may not be the resources to place post-pyloric tubes very successfully. So many times you may put a tube and you may have to go to the radiology, or you may have to get it done under interventional radiology. If you have the ability to place them at the bedside, that doesn't cause delay, then for sure post-pyloric, the interruptions and intolerance is much better. Now, what's necessary is that post-pyloric is always continuous. You can't do bolus feeding. So there is this component where post-pyloric represents not just where you're delivering, but how you're delivering, whereas gastric is always bolus. So there are continuous versus intermittent trials that are also currently going on. There's one about to be published in within the next month, and that will guide us a little more if the way and the site where we deliver nutrition is one better than the other. But most people are using post-pyloric after or if they can't do gastric feeding.
Yeah, and another thing is how about the contamination of the gut because of post pyloric feeding? Have you met the GI episodes of diarrhea or explosive stools with post pyloric feeding? How
Yeah, that's a
common
great
are they?
question. Great question, because particularly if these patients have starved for a long period of time, they have a lot of villus atrophy, and the ability for them to tolerate right off the bat a very high density caloric and protein full non-elemental diet. Many of them will get into diarrhea. So that would be something you would watch for. In many of these cases, with prolonged fasting, people may have to resort or change the formula to try to be a little kinder. One way to eliminate that is to start trophic feeds, even gastric, right from the beginning, to allow the mucosa and the villus atrophy to be avoided. And we see it every now and then. I don't think it is predominantly worse in post-pyloric versus gastric, because we start slow and do stepwise and then slow down if it is not being tolerated.
We'll go to the questions from chat box. One is there any different enteral nutrition formulations based on the disease like sepsis, surgery, renal failure?
It's a great question. I wish there was an evidence-based answer to that. There isn't one. In adult world, as you know, there are many studies where people have explored. So there are three types of formulas that one can conceive that may be based on the disease process. The first one is, if you remember the concept of overfeeding and the concept of CO2 elimination as part of the metabolic process. So if I am getting a large amount of caloric overfeeding, particularly from carbohydrates, my CO2 elimination is very high compared to if I was getting lower amounts and predominantly through fats. And in patients with long-term chronic ventilation issues or who are dependent on respiratory support or with failure, people have shown that altering their diet based on the amount of carbohydrate composition to decreasing carbohydrate and increasing protein and fat has decreased CO2 burden on them. I didn't have time to show you our individualized study, but we've actually gone to home ventilated patients' homes and altered their diet and shown CO2 elimination decrease and mechanical ventilation duration decrease. Similar studies in adults where they've done 6-minute walk test after a large meal in patients with cystic fibrosis or patients with chronic lung disease. And you see functional changes based on a overeating of carbohydrates. So that's one aspect of the formula, which is composition. The second aspect is the immunonutrition, which is people have tried to use fish oils and combinations of omega-3 fatty acids or fish oils. And while there is some adult data, there is no pediatric data to say that we have shown immunonutrition to be beneficial. So there are some products and people are using them as in an individualized basis, but it's not evidence-based. There is no RCT. The one big RCT was from Joe Carcillo, who is a colleague in Pittsburgh, and he did the crisis trial. And in that, there was a combination of immunonutrition in the form of glutamine and other products, zinc, and then one prokinetic. And he didn't find differences between them in terms of sepsis patients. So I think there is a role. I just think we need to select these patients carefully and maybe a different study design than the one which we usually practice, which is let's take everybody and then put them all into one category or the other, which is not how nutrition works. And therefore, we have not been able to show the benefits. I hope that helps. I don't see any evidence yet that makes me change to a certain nutrition formula for a large number of patients.
Okay.
Oh, and the third one is related to the first question, which is the elemental versus non-elemental, which we use routinely. So if you have intolerance to certain full complete formulas, we do resort to semi-elemental or elemental diet. So those are the three ways I think of it.
Yeah. So about the immunonutrition, actually I have not published the data, but one of my student, Dr. Raunak, did a study in PICU where we have randomized 30 children of pneumonia needing ventilation versus 30 not needing ventilation. And we have found good results. Maybe it
Nice.
just reminds me that I should publish it.
Absolutely, yes, yes. Yeah, and there are some smaller trials like that which are beginning to hint at some changes. I think a trial where patient selection is very careful and the outcomes are relevant would be very appreciated, and we need to go there. It's an interesting area.
Another question is the sick children below 6 months in PICU enteral nutrition equivalent to express breastfeeds?
Oh, absolutely. I think for all those patients in the NICU, even up to 6 months, um, we encourage the mothers to express breast milk from day one, even if their child is not ready to feed at that time. And if you were to choose between a formula versus express breast milk, there is no doubt that express breast milk is the go-to number one, 100% more beneficial to these children. In some cases, it is possible that you may need to supplement on top of that, and the dietitians are very good at understanding the limitations in some disease processes, and also depends on the volume available to you. But there is no doubt that we would use express breast milk as our number one go-to formula.
Another one is what target calories per kg and proteins per kg would you suggest for a sick, malnourished, intubated child if indirect calorimetry is not available, which is a very common scenario?
I completely agree. The indirect calorimetry is so difficult to get in most centers, and although it's becoming better, I hear last time I was in Mumbai, I saw a lot of people saying that they are beginning to get access to it. But even in centers that have indirect calorimetry, many of these patients are not eligible. They might be on high FiO2. They might have not stability enough to give a good result or a reliable result. So in those patients, what we do is we use the estimating equations. Amongst the estimating equations, several of us have published that when you measure and compare it with the estimated equations, most of them are inaccurate, but couple that come close are the WHO or the Schofield. So we use the WHO or the Schofield equation. That's the first step. The second thing is we don't think that you need to get to 100% of whatever is your prescription. So you need to be careful. We don't put stress factors. We certainly don't prescribe a lot more than 100%. But the specific question was a malnourished child. So it's possible that a dietitian may individually alter the prescription to either go above or below to prescribe that. But then the delivery, we don't rush to try to get to 100% of that, but maybe at least 60 to 80% of what you prescribe. Now, you ask in terms of calories per kg, that is such a difficult, that's not what we want to do. We don't want to have 1 kcals per kg for that entire group. But what we found is that very often the number that comes to mind is not 100 kcals per kg per day or greater. Based on our measurements, we found them more to be close to 60 kcals per kg to 80 kcals per kg in that particular age group. So it's possible that 80 kcals per kg is more than enough. As far as protein is concerned, we are in the middle of trying to answer that question with appropriately designed randomized control trial. But based on everything that we have in our guidelines, both as SCCM and ASPEN, we've talked about 1.5 grams per kg as if you were to pick a number, that's a good one to start with. And once again, we don't try to get to that within first 2 to 3 days, but by day 7, you should be giving 1.5 grams per kg per day. Does that help? It's not a perfect answer because the whole concept is individualized. So anyone who comes and tells you a number is probably not going to be right in many cases.
Yeah. From Dr. Mohite, we have a question. When do you start monitoring muscle mass? And do you plan nutrition correlating with the muscle mass?
It's a great
Dr.
question.
Dr. Alka and Dr. Nilesh, I really hate to break it up, but I think this could be like a last question. Then maybe you could continue to answer them on the chat if that's okay.
Sure. Yeah. Thanks, Neil. That's a great question. I think right now we are at a phase where we are beginning to use it in trials and studies as opposed to letting everybody drive their nutrition delivery based on the muscle mass. We wanted to start by first deciding what's the perfect protocol that all of us can do without getting inaccurate results. And encouraged by that, we are now using it in certain cases with a lot of thought, but we are studying it. So hopefully in the next 1 year, we should have data to suggest whether we can have therapies that can be tailored to muscle mass. In fact, in one of the editorials that we wrote, we said muscle mass and ultrasound might be the new biomarker to guide some of our nutrient delivery. We are almost there, but I'm hesitant to say that's what everybody should do until we can show it in a trial. So in the observational studies, there's actually correlation, as I showed you, between what you deliver and muscle mass, but I would hesitate to go a little further. Maybe by next year, we can use it more or not based on the trial results.
Just one question, if you don't mind.
Mahesh, I would just want to
Okay.
interrupt one thing before. Yeah, thank you. So excellent talk, Dr. Mehta, and I really became very obvious the big Atlantic division between what we had a talk yesterday from Shasha from Europe and what you spoke about today. And that's a great thing for the science that will make both of your groups to do more RCTs and get the answers by RCTs. At present, what the RCT shows should be the standard, and it's always a cycle which we keep on changing and learning. We started with underfeeding, we went to, as you showed, overfeeding, way overfeeding. Now we might come down to somewhere in between. We might start TPN early, or we might start TPN late. You said that on ECMO patients you all start TPN early. I come from Glenfield. We do about 300 ECMOs a year. We don't start TPN until 4 or 5 days. So that's a European thing. So it's good to have this discussion and have both this view. Excellent. And what most important thing is that you said this, the important to individualize each and every patient, whether it's a it's a newborn or an infant or does not work. And I feel that's at least one basic thing we should take from this. And with that, I would say that we'll ask Dr. Jadhav and her team to please start the case.
Dr. Amish, let us have a question from Dr. Mahesh. One question.
That's okay. Only one question,
Mahesh.
quick one. We used to do non-protein calorie to nitrogen ratio to monitor this. Is it really effective still? Are you, because that we do in neonate quite often. In pediatric, we haven't followed. How does it really matter? Is it really essential to follow?
Yes, we actually still do that. In fact, we wrote a paper with with our colleagues from Brazil, where we looked at thousands of patients and hundreds of formula and looked at what their non-protein to protein calorie ratios were. And there seems to be a signal. So in fact, it's a good concept for people when they talk about formula to understand whether you are choosing the formula that will make you succeed with the low calorie and optimal protein. So it's still a concept. I think we should be talking more about that. It's a great question, Dr. Mohit. Thank you, Neil and Dr. Jadhav. Over to you.
Thank you very much. We have to discuss one case which we have managed with our protocol. I think I'll reserve my comments later for the later part of the discussion to start or present with the case. Is the screen visible?
Yes, ma'am.
We have Dr. Sanjeevani Masavkar. She has been working as, she has been an associate professor. She is in charge of Department of PICU in our department. Her areas of interest are pediatric intensive care, pediatric cardiology, infectious diseases, and pediatric nutrition in intensive care area. The case will be presented by Dr. Leena, and we have Divya Ananta Subramaniam. She is working as a pediatric nutritionist at Nutrition Rehabilitation Research and Training Center of LTMGH, LTMMC.
Madam, just one sec, madam. We'll have to start. We are really getting behind on time.
Yeah.
Thank
She
you.
is the registered dietitian, and she was involved keenly in trial with Dr. Nilesh Mehta about nutrition in PICU. Over to you, Leena, Sanjeevani.
Madam, you have to,
I have to.
share the screen with Leena. So you have to unshare yourself.
I have to stop sharing. No?
Yes, madam. Yes.
Yeah. I
Now, Leena, you can start.
Can you hear me?
Yeah, we can hear you.
Yeah.
Start sharing. Yeah.
Is the screen visible?
Yeah, is the screen visible?
Yes.
Yeah.
Yeah, okay. Good evening, and after this excellent lecture by Dr. Nilesh, I will be presenting case from PICU, and then it will be the nutritional aspect will be discussed by Divya. Next slide, please. So this is a 3-year-old male child weighing 10 kg who was brought to us with history of weakness in both lower limbs, gradually progressing both the upper and lower limbs. Patient had difficulty in swallowing since 2 days and inability to bear weight, and frequent falls started since last 8 days. Patient was taken to practitioner at native place in UP, and where he was advised, given some medication, and was advised to go to higher center for admission, where advised investigations like CT, CSF20 and IBIG, but relatives gave negative consent and patient was brought to Mumbai. Next slide, please. So here, initial examination, patient was conscious oriented, having weakness in all four limbs with hypotonia and weak gag and normal color breathing pattern. Yeah. So initial impression was sick child with neurological affection. Next, primary examination, there was airway was normal, breathing, respiratory rate of 30, increased tidal volume, SpO2 maintaining at 98 on room air entry clear. On circulation, heart rate was 112 per minute, pulses well felt, CRT 3 seconds, periphery is warm, but patient had hypertension on 95%, 99 percentile. And in disability, patient was pupils reacting to light following commands, weakness in all four limbs with weak gag. In exposure, there was nothing significant. Next slide. So on CNS examination, patient was conscious oriented. These in all four limbs, power was 0 in all four limbs, truncal weakness present, deep tendon reflexes absent, superficial reflexes absent. Patient had weak gag, no meningeal sign, and no bladder involvement. The rest of the respiratory system, there was just mild tachypnea and severe per abdomen was normal. Possible etiologies, acute flaccid paralysis with GBS. Next slide, please. So patient was interventions done was a patient intubated in view of weak gag and swallowing, and was routine investigations, basic investigations, RFT, electrolytes, HIV, just COVID, RT-PCR was done. Patient was shifted to PICU with minimal and ventilated on minimal ventilatory settings. MRI spine and brain was planned. Patient was, it showed mild thickening and intense post-contrast cauda equina nerve root enhancement suggestive of GBS. So patient received 2 gram per kg of IVIG over 2 days. MRI was, brain was normal. AFP reporting was done. Next slide, please. So these were the initial investigations. Patient has low hemoglobin, total counts were normal, and rest of the SGOT was slightly elevated, and proteins were 5.8 and albumin 3, RAT negative. This patient initial blood culture was no growth. Next slide, please. Next slide, please. Divya. So daily monitoring of new complaints, vitals, muscle charting, and reflexes were done. Next slide, please. Child in PICU, child developed one episode of convulsion with staring loop, for which he was loaded with anticonvulsant. Patient had autonomic instability in the form of hypertensive readings, for which he received anticonvulsant, clonidine, and mechanical ventilation with ET continued for 3 weeks with CPAP trials when given, but there was no improvement in power, and weakness of intercostal muscles didn't improve. So meanwhile, patient developed VAP with Acinetobacter. So tracheostomy was done. Antibiotics were stepped up according to sensitivity pattern given for 21 days. Gradually, patient was weaned off one ventilator and kept on minimal oxygen and shifted to ward. So these were the pneumonia he had, ventilator associated pneumonia. Next slide, please. treatment received 14 days of antibiotics, which were stepped up for VAP according to sensitivity, and IVIG, ventilatory support by tracheostomy, anticonvulsant, antihypertensive medicine, gabapentin. Patient received multivitamin, calcium, vitamin D supplements, zinc, supportive care, chest and limb PT, and enteral nutrition support. So at admission, assessing the nutritional status, patient had a height of 10 and weight 86 centimeter. He was moderate acute malnutrition. Weight for height was between -2 standard deviation to -3 standard deviation. And according to Schofield's caloric requirement, he was it was 690 kilocalories, and protein requirement was 20 grams. During patient was initially started on trophic feeds, and then gradually it was increased. Next slide, please. So what are the common causes where patient can have nutritional deterioration in ICU settings? Like if there is a gastric intolerance, stress ulcers, paralytic or septic ileus, or patient has shock or increased catabolism and delayed initiation of enteral nutrition. Next slide, please. So our patient was started on trophic feeds initially and increased gradually within 2 days. Patient developed intolerance as feeds were withheld for 1 day, kept NBM for MRI, and then restarted gradually over 2 to 3 days, increased to 120 cc per milk 3 hourly, and that was within 4 or 5 days we could achieve that. Started nutritional pediatric supplement, intact protein with kitchen-based blenderized food. Then once medically stabilized, patient feeds tolerance was achieved. The child was referred to nutritional rehabilitation. PICU. Initial, there was gastric intolerance, so there was delayed enteral nutrition. Then patient had autonomic instability in the form of tachycardia, systemic hypertension, interruption in feed for hemodynamic stability during acute surges. Patient was kept NBM for procedures, and ventilated associated pneumonia, increased metabolic rate. Patient had prolonged recovery from muscle weakness, which led to a severe muscle wasting. Next. So how we tackle this patient's nutrition, that I'll ask Divya, nutrition expert from our department, to talk on. Thank you.
Thank you, Dr. Leena. Good evening, everybody. So I will be dealing with the nutritional management of this case. So up till now, I think we've established that the child had GBS, and when he was admitted into the PICU, the child had a nutritional status of moderate acute malnutrition. So we just wanted to analyze what was his home diet recall and how much of his nutrient intake was deviating from his requirement. So the interpretation says that he was exclusively breastfed. Complementary feeds were initiated from 6 months of age. He was bottle fed. The diet lacked dietary diversity. The diet was deficient in most of the macronutrients and also a lot of the micronutrients. And the diet met up only 40% of the recommended dietary allowance for age. So nutritional status on admission into the PICU, as per the WHO and the IAP growth standards, the child was determined to be having moderate acute malnutrition, especially by the mid-upper arm circumference. So what were the nutritional goals of management for this case? The first one was to maintain the fluid and electrolyte balance, to correct and prevent any nutritional deficiencies, to promote the catch-up growth because the child was also very malnourished, to prevent starvation-induced wasting in the form of loss of lean body mass, and to improve and maintain quality of life. So the nutritional requirement was determined by using certain predictive equations, like I think we've discussed up till now. We can use Caulfield equation to determine the basal metabolic rate. We do not wish for overfeeding these patients, and since we did not have access to indirect calorimetry, we relied on predictive equations to determine the energy intake. So the energy intake calculated as per Schofield came up to 690 kilocalories. Protein requirement, since the child was already the child had moderate acute malnutrition, we wanted to start off with a higher protein intake of 2 grams per kg body weight, which came up to 20 grams per day. This was 12% of the total calories, and a higher protein intake was suggested to promote catch-up growth and to prevent loss of lean body mass. And the deficit, as per his consumption, is of 9 grams. Fat intake was recommended at 25% of the total kilocalories, which is 19 grams per day. Medium chain triglycerides usage can prove to be beneficial at this stage, and carbohydrate requirement was anywhere between 60 to 65% of the total kilocalories, that came up to 108 grams per day. Moving on to the micronutrient supplementations that were provided. Moving on to the micronutrient supplementation that was provided to this patient. The patient was supplemented with zinc, vitamin A, E, D, calcium, trace element supplementation was provided, and B complex multivitamin supplementation was also provided. Moving on to the enteral nutrition feeding plan, like I think Dr. Leena has already mentioned, the child was eventually started on full feeds, that is 120 cc per 3 hourly feeds, and these are bolus feeds. So here the child was started on kitchen-based blenderized feeds as per the hospital protocol, and the child was simultaneously started with a standard nutrition supplement, which had the type of protein was intact protein in nature. Then to supplement the plan furthermore for additional calories, the diet was supplemented with MCT oil, milk, and sugar. So the total energy intake via this chart was 720 kilocalories. Carbohydrates were 57 grams. Protein was 38, which is 3.8 grams per kg body weight, and fat was 16 grams, which is 20% of the total calories. So this particular diet plan that I just discussed was followed when the child was diagnosed to have moderate acute malnutrition, and that continued for quite a few days. Then subsequently, it was realized that the child's weight was kind of stagnant, and then it started deteriorating furthermore. So again, a repeat nutrition reference was recommended. So this is when we identified that the child's anthropometrical indices had decreased, wherein his weight had dropped from 10 to 9.2 kilos. His length remained the same. There was no increase in the length. And the MUAC of the child had dropped from 11.9 to 11.2, indicating that the child had severe wasting. And now the child could be called as, can be diagnosed as severe acute malnutrition by MUAC as well as weight for height standards, by both as per WHO reference standards as well as the Indian Academy of Pediatrics standards. So just talking about the progress on enteral nutrition feeds, due to prolonged periods of ventilation, we could not weigh the child periodically. The length of the child could not be measured accurately. These were certain limitations that we faced. The mid-upper arm circumference was utilized to analyze the growth trajectory of the child in this case. So this was measured bi-weekly. We noticed that despite providing a nutritionally adequate feeding plan, the MUAC of the child still decreased it went to less than 11.5 centimeters, indicating severe wasting. So this was considered as an indication for starting a much aggressive nutritional management by using ready-to-use therapeutic food, which is especially utilized in the management of severe acute malnutrition. So just to give you all a brief as to what is this ready-to-use therapeutic food, it is considered as a gold standard by UNICEF in management of severe acute malnutrition or severe wasting, especially in the age group of children aged between 6 months to 5 years. It is an energy-dense formulation, micronutrient enhanced paste, which is used as a therapeutic feeding tool. And here there is no additional nutrition supplementation which is required. No refrigeration needed, no cooking. Shelf life is up to 2 years. So this can be used in resource-limited settings. So this is the medical nutrition therapy that is produced at our nutrition rehabilitation center attached to Sion Hospital. The major ingredients are soybean oil, groundnut paste, sugar, skim milk powder, micronutrient powder, and emulsifier. So this is the nutrient composition. The nutrient composition is such that it is double the RDA because it is for a severely wasted child. So it is double the RDA of a healthy child. So since we prepare it at our center itself, it is indigenously produced at our center. This is the process of manufacturing wherein the peanut paste and all of the ingredients are mixed together in a mixer. It is then further ground into a finer paste. Then it is directly packed and sealed into a cup or in a sachet pack. So what are the indications for starting RUTF? Presence of either one or more of the indicators that are mentioned below. So the age group of the child should be at least 6 months to 5 years of age. If the child has a weight for height or weight for length less than -3 SD as per WHO growth charts, or if the child has presence of bilateral pitting edema of nutritional origin after ruling out any of the organic conditions, or if the child has a mid-upper arm circumference of less than 11.5 centimeters. So in our case, the child did have the first and the third category. He did not have any pitting edema, bilateral pitting edema. So this is the reason why the child was started on ready-to-use therapeutic food. Now, this is the algorithm that we use in management of severe acute malnutrition. Since the child had a prolonged length of stay in the PICU and he was already medically stabilized and he was nutritionally stabilized to a certain extent by providing a standard nutrition supplement, he did not require any more stabilization that is usually recommended for a child with severe acute malnutrition. So the concept of appetite test becomes redundant for this particular case. So we directly started the child on ready-to-use therapeutic food by omitting the steps of starting the child on F75 or F100. So what was the nutrition regimen that was started when the child was started on RUTF? The child still had a rice tube feeding plan. So since the child had 8 feeds in a day, 3 hourly feeds, for first 4 feeds were planned with two TSPs of the ready-to-use therapeutic food, which were diluted in 100 ml of cow's milk every 3 hourly. The rest of the 4 feeds were planned with 2 TSPs of ready-to-use therapeutic food diluted in 100 ml of water every 3 hourly. So we started with 1 sachet of ready-to-use therapeutic food per day to check for tolerance, and to also, since the child was severely malnourished, we did not want the child to slip into refeeding syndrome. So we started slow. So this was the plan, and we started with 1 sachet per day. So course of management in the ward, the child was weaned off of the ventilator and he was eventually shifted to the pediatric ward. Continuous OT, occupational therapy rehabilitation was done to promote oromotor stimulation with continuous physiotherapy rehabilitation for limb exercises and chest PT. Nutritional support continued with RUTF via nasogastric tube feedings. The child started to tolerate oral test feeds. He could eventually swallow liquid to semi-solid feeds, and eventually the rice tube was removed and oral feeds, in the oral feeds, semi-solid in consistency, they were initiated. Eventually the child was discharged from the ward on oral consumption of ready-to-use therapeutic food with a high protein diet. And he was advised to follow up every fortnightly in the nutrition OPD. So this is the growth trajectory of the child, wherein since once he was referred to us, originally the child was ma'am, and now that he's following up with us, you can observe that the weight and the height of the child is slowly and gradually increasing. I wouldn't say that he has optimally come out of malnutrition because he does have underlying conditions, organic conditions. The pace is slow, but he's definitely showing good progress at the moment. And he's still following up with us. So at the 5th follow-up, at his last visit, he was still having moderate acute malnutrition. So this is the pre and the post photo. This was clicked when the child was intubated in the PICU, and the second picture was clicked when the child was in the ward. So currently on follow-up, the child consumes at least 2 cups of medical nutrition therapy per day. He can walk without support. He eats from the family pot. He can chew food and swallows all the feeds without any hindrance. And the developmental milestones are also improving. This was just a slide that we decided to show since this was just a case-based discussion. I think majority of this has been covered in the previous talk. So moving on to the pearls of nutritional management in critical patients. Early enteral nutrition as early as within 48 hours of admission into the PICU after hemodynamic stabilization is recommended. Minimal interruptions in enteral feeds for the procedures and investigations is recommended. Avoiding too long hours for fasting. High energy, dense, low volume feeds are recommended. Strict asepsis in PICU to prevent nosocomial infections, and early nutritional guidance from a nutrition expert and close monitoring of the nutritional status and prompt intervention is recommended. So these are just certain potential areas of research that where we could kind of evaluate the impact of RUTF in critical care settings. So one such area of potential research could be use of RUTF for a period of at least 2 to 4 weeks in any of the nutritional, in either malnourished or a child with a normal nutritional status in a critically ill setting, to check for to prevent nutritional deterioration. And we can also evaluate micronutrient requirements of critically ill patients who do not have severe acute malnutrition. So the only take-home message that we have is RUTF, that is ready-to-use therapeutic food, can be used for nutrition rehabilitation of all critically ill SAM children and vulnerable MAM children to promote recovery. So, thank you. I think Dr. Alka Chadav ma'am has a few comments.
Yeah. Thank you very much, Divya. I would like to have, we have almost 12 chats. I'll just see what all are the chats.
I think those chats were uniformly congratulations on managing a challenging case really well.
Okay. So thank you very much. To tell the probably audience that we have modified the conventional ready-to-use therapeutic food, which contains peanut paste. We have used a low folate medical nutrition therapy for children with oncology. We have finished almost 300 children with Tata Memorial Hospital, and this randomized case control study is published in the Blood Journal of this year's March, actually, and it has been appreciated well. All oncology related malnutrition, we have been using low folate MNT because folic acid component is used as physiological dosages. We have also managed that many of our SAM children, they come with chronic and repeated diarrheas. Also, the cost of peanut paste is much more, whereas cost of soya is much lesser. So we have come out with a soya-based MNT, which uses processed soya flour, and rest all compositions have remained the same. And micronutrients we have modified or we have tailor-made depending on the micronutrient analysis. This has also been published in International Journal of Medical Research last year in November 2020, I think, or 19. So these are the modifications which we have done, and we regularly help Tata Hospital, and we are initiating a new study on starting in stem cell transplant, the RUTF in post bone marrow transplant. That is a new study which we are initiating with Dr. Manglani at our CTC Center, Borivali. So I thank Divya for such a wonderful presentation, and Dr. Sanjeevani for really assisting and making the presentation a great success. And I thank Dr. Neil and Dr. Amish Vora to give us an opportunity to project our nutrition related work. Thank you. Any questions or comments, they are welcome.
No, thank you, madam. Dr. Sheikh will give the vote of thanks.
Yeah, before I go for the vote of thanks, I'm Dr. Sheikh, working at Lilavati Hospital, Mumbai as a consultant pediatric, PICU. Before I really go into that, I look at certain seniors over there. I would like to have a word from Dr. Siti Deshmukh sir. He's been there since beginning. So Siti Deshmukh sir is a professor at KM Hospital and his presence is always welcome. So can you please unmute yourself, video on, and have us 2 words.
Very well pointed out, Chief. We all are his students only.
Yeah, City Deshmukh sir.
All of us. So yeah, sir.
Sir, you are there? Yeah, please make your video on, sir. City Deshmukh sir.
Or it's a 10 past 10.
Okay.
So you can just talk, sir.
Okay, that's okay. So
You can hear?
yeah, we can hear you, sir.
I'm
can hear you,
fortunate to hear 2 of my students speak today. Dr. Nilesh Mehta was my first student, and Dr. Leena's was my student also. And it's a very good presentation and management of the case by Alka and her team. And of course, it was brilliant listening to Nilesh again. It was a very well arranged thing. I enjoyed and learned a lot. Thanks a lot.
So thank you, sir. And it's my privilege to thank you all in brief. At the outset, we must thank our great speakers, Dr. Nilesh, who always we wish to listen to him. And the way he has taken us about the nutrition is phenomenal. He has actually talked about the practical problems day in, day out that we encounter and we stuck. And your all those evidence, it's all evidence based. So thank you, Dr. Nilesh. The team, Alka Madam, Sanjeevni and Divya. I must say the presentation was excellent. Not only in terms of look visible, I mean, in terms of your slide preparation and all, but the content and the management. It was real pleasure to have you all on board. With this, then we have Dr. Neil, who has always been very encouraging, our dynamic young intensivist who has a lot to store in days to come. So thank you, Neil. And our president, Dr. Parmanan, he has always been, he is always off screen. We want him to be on screen, but he's always, but a lot of help from him. And our joint secretary, Dr. Lakshmi, Dr. Rekha. I also see Rekha from the beginning. He's been very kind and a very practical human being. So thanks you all. Once again, I thank our technical support, Bhavik, our delegates who have been there till now. So with this small thank, we wind up and see you again. Great thank.
Thank you all. I really appreciate you inviting me, and what a special treat to be with you on this auspicious in the middle of your festival there. And I'm sorry that we are doing this over Zoom. I look forward to seeing all of you in person and hopefully welcoming you to Boston. So it's a big treat to listen to this fantastic management, Dr. Jadhav.
Yes.
Both Dr. Sanjeevani and Divya did such a fantastic job. I thoroughly enjoyed it, and hopefully we can collaborate and learn more. Dr. Sheikh, thank you for your kind words. You're very kind. Amish, Neil, thank you for inviting me. And my very special treat to hear from Dr. Deshmukh. He's truly a pioneer and has trained and influenced a whole generation, just like some of you. So
yes.
Enjoy, be safe, and I hope to see you in Boston or Mumbai soon.
Thank you, sir. Thank you all.
Bye-bye.
Great presentation, great day.
Thank you all.
Dr. Brahmanan, thank you.
Thanks.